All right, everyone, we're just going to wait a few moments for people to start coming in, and then we'll go ahead and get started. All right, so hello, everyone, and thanks for joining us this afternoon for How Piedmont Healthcare Optimized OR Scheduling and Perioperative Workflows. My name is Jordan Leibovitz. I'm part of the marketing team here at IMO Health. Before we get started, I want to take care of a few items for those attending. This webinar is being fully recorded and will be available to you after the webinar, so be on the lookout for an email in your inbox. All attendees will be in listen-only mode, so if you have any questions or comments while our panelists are speaking, just type them into the Q&A box on the bottom of your control panel. Today we have two speakers, Allison Keller. She is the Vice President of the Patient Connection Center at Piedmont Healthcare, and our very own Wes Galbo. He is a Senior Vice President of Product Manager here at IMO Health. So without further ado, I'm going to pass it over to you, Wes.
Thank you, Jordan. So today we're eager to hear from our partner Piedmont regarding their experience in a surgical scheduling improvement. Before we get into that, I wanted to provide a little context regarding IMO Health, where we sit in the market, and how we help our clients improve healthcare data quality. For more than 30 years, IMO Health has been enabling clinical data quality across the healthcare ecosystem. We make data more precise, useful, and valuable for patient care, billing, population health initiatives, research, clinical trials, and more. At the heart of IMO Health's portfolio is industry-leading clinical terminology. We essentially manage the complexity of the millions of words and phrases used to describe patient conditions and treatments, including synonyms, abbreviations, acronyms, regional slangs, and language describing where, when, and how a problem or treatment may have occurred. We then manage mappings to all of the continuously changing regulatory coding systems, such as ICD-10, CM, SNOMED CT, CPT, LOINC, RX Norm, and more. We then apply this clinical terminology to industry challenges. At the point of care, IMO Health enables physicians to capture precise granular diagnoses in their own words, and then include the necessary mappings to industry code sets required for billing and regulatory compliance. We make problem lists more accurate, meaningful, and comprehensive. We also furnish extensive lab, medication, and procedure terminologies to power more efficient ordering and reporting. And as we mentioned, and we'll hear more from Piedmont, we optimize surgical scheduling workflows and OR efficiency with standardized surgical dictionaries. Beyond the point of care, we also offer data quality management solutions that standardize and enhance that same patient condition and treatment data that comes in from disparate sources, making it consistent, enriched, and ready for analytics. We also help simplify the process of defining and managing clinically consistent patient profiles and value sets. With that experience, we are effectively integrated into all major EHR vendors: Epic, Oracle, Cerner, Meditech, Altera, NextGen, athenahealth, Paradigm, etc. With that, we also reach more than 70% of US hospitals today, and effectively nearly 90% of US physicians are benefiting from IMO's terminology at the point of care. That same clinical terminology really for us is a core competency, and we have the staff on hand and the clinical expertise to continue to evolve that for a variety of different use cases. As I mentioned today, we will be hearing from Piedmont regarding their experience for our IMO Core Periop solution. That is a standardization and maintenance solution that allows for very crisp, clear procedure terms with CPT and HCPCS mappings, as long with a number of different solutions, such as flags to ensure appropriate scheduling of CMS inpatient-only procedures, patient-friendly companion language that helps improve patient communication, and effectively gives our clients a benefit to maximizing OR efficiency and optimizing reimbursement. By reference point, IMO Core Periop is helping more than 120 health systems and operating rooms today. We are powering more than 35% of Epic's Optime deployments. And that clinical terminology component that I mentioned, we have an extensive library of terms that allow for surgical schedulers to map those procedures according to language that's familiar to them. And in part of our solution as well, embedded is AORN's Integrity industry-leading surgical terms and procedures. Allison will share her experience with Piedmont here in a minute, just giving you some background regarding some of the customers we've helped today. In a 12 hospital system with 90 plus clinics, some of the benefits of using a clean surgical dictionary include reduction in inpatient only denials. We have seen evidence in some of our clients, they are reducing those denials by more than 50% over 1 year periods, which is immediately contributing to reclaimed revenue. We have an integrated health system with 9 hospitals that's experienced an increase in case duration accuracy by 13.7% in a pre-post implementation period. And so we are seeing real benefits regarding the nature of improving a surgical scheduling dictionary. With our experience, just wanted to share some of our findings, IMO Health, that is, when we work with clients to improve the quality of their surgical dictionary. I'll share with you some statistics from the 120 plus health systems that we've assisted today. We find when we first examined existing surgical dictionaries that they are bloated in many cases just by the nature of those particular solutions. Oftentimes, up to half the time, we find those dictionaries contain deactivated or unused terms. Some of those may be duplicates. Very often, more than 3/4 of the time, we are finding procedures that are missing CPT codes or HCPCS codes. Oftentimes, we will find that they are incorrect mappings to CPT codes. And ultimately, that makes for a very difficult scheduling workflow if that inconsistent data is applied. And implications obviously impact downstream things like pre-authorization and billing. So it is a real problem that we're excited to help our clients solve. And happy now to welcome Allison Kessler from Piedmont, and she will share some of her experiences regarding a clean surgical dictionary.
Thank you, Wes. Good afternoon, everyone. And I'm happy to be here to share my experience with IMO. IMO and Piedmont have been partners for almost 10 years now, and so definitely have some insights to share regarding that. So just a little bit about Piedmont. So Piedmont is based in Georgia, with our headquarters being in Atlanta, Georgia. We are now 25 plus hospitals, and we perform over 138,000 surgeries per year. So we cover 80% of Georgia, or of the population of Georgia. And the fun fact I like to throw out there for many that may not be aware is Georgia is actually, we have the largest landmass east of the Mississippi. So covering 80% of Georgia is not a small feat, and especially once you get south of Atlanta. So, but I have been with Piedmont for 15 years now. I really, when I came into the world of surgery, I was overseeing surgery scheduling for our flagship location, as well as the business manager for that location. Since that time, as Piedmont has grown, I have grown within Piedmont, and I am now the vice president of Piedmont's Patient Connection Center, and my team has responsibility for scheduling of all surgical cases, as well as endo-cath EP cases across the 25 facilities that I mentioned. We also handle scheduling for all outpatient services at the hospitals, support our primary care and cardiology practices with incoming calls. I'm also responsible for obtaining authorization and getting insurance verified, and creating estimates for all of those services. So that is kind of how all of that ties together, and why I was so interested in utilizing IMO. So a big piece of what has happened over time with Piedmont specifically is growth, quite a bit of growth. So when we first went live with IMO, we had 5 facilities, 5 hospitals, and so we had just not too long before that came out of a EHR merge. So we had moved all of our 5 hospitals over to be on Epic. As we had brought those facilities on, we did some manual cleanup of the procedures and the categories and so forth, but we really still had some duplication of those codes. We did not have any CPT codes linked to those. And we really, although we somewhat tried to have standardized naming conventions, we really did not have those. And so what we were missing and what we were really trying to accomplish at the time were a few things. It was really around the inpatient only procedures that, like Wes mentioned earlier, it was around making sure we were getting correct authorizations, as well as those case durations, trying to get those correct, and then patient safety with making sure we had the services right. So again, we really had to look for something. One, we're an Epic shop, so we needed to look for something that we knew worked well with Epic. I learned about IMO at one of Epic's user group meetings, and so we just kind of went from there. And so, and then I think the important thing to know is then as we've grown from 5 hospitals to 25 hospitals and have integrated all of those, having IMO in place has really allowed us also to make sure that we didn't just keep importing additional information into our Epic system, but really helped us to make sure that we had a clean list of terms that we were using, that those were standardized, and that we did not have duplication. So that has really been what our focus has been on throughout this time of strategic growth. So I talked a little bit about this, but I'll dive into this just a little bit deeper. So again, before, I mean, our process was really if somebody needed a procedure added to the surgical dictionary that we had in Epic, then they would request that. Somebody would then maybe go out and review the CPT code. If we got a CPT code, again, we weren't even putting those in Epic, so the CPT code maybe was used just to help us with making sure we were getting our terminology correct. And then it was just kind of a group effort to determine what would be the best term to use and to put into the system. So what that really caused, again, as I mentioned, was duplicates. But again, the biggie was we had no CPT codes linked to our procedures. And so we had surgeons' offices that were also asking to be able to schedule by CPT code. We had feedback from our authorization team that they did not have the CPT codes that they needed to be able to do the authorization. So we needed to get that. We also really didn't have a good way of maintaining our procedure list every year, or even quarterly as any updates came out, because we were reliant on someone from maybe coding or revenue cycle to let us know that those needed to be updated. And then again, really because of the lack of standardization, we really had challenges with our case durations and just how things were being scheduled. So you know, I always liken surgery scheduling to somewhat a game of telephone, right? We aren't all speaking the same language necessarily. You know, typically the surgeon seeing a patient in his or her office, just determining that they're going to do the procedure. Maybe now they put it into their EHR and that goes directly to their surgery scheduler. But historically, right, they were writing that down on a piece of paper that goes to their surgery scheduler, who then calls the hospital's surgery scheduler to get it on. And then the surgery scheduler is trying to look in this in Epic in our case for what that is. And again, we aren't all using the same terminology or calling things the same thing. So so we really knew that we needed to do something different. And so again, what IMO really allowed us to do was we reduced that duplication of terms that we had. I mean, I will say we still have some minor duplication, but that is intentional duplication, meaning for, let's say, a robotic surgery versus a non-robotic surgery, where we will we have a term that just has robotic in front of it. So we know that this is something that's going to be performed robotic, since the CPT code and the CPT code description really is the same, regardless of the approach. Again, it did allow us to have some more specific and detailed terms. We actually utilized IMO to take one of the things, even after we went live, that we discovered was that for our spinal surgeries, right, that we were still having some challenges, especially with durations. And that is because, even within, even if you're doing a L spine, you have multiple levels that you can do. You could do one level, or you could do 7 levels. And so we need to know, how many levels are going to be done really helps determine what that duration is going to be. And so we actually utilized IMO to help us with even breaking those down into some more specific categories. And then the big thing we really did too was utilize that inpatient grouper. So the IMO terms come over. It tells us all of the codes that are inpatient only. It has a grouper on there, an identifier. So one thing that we put in place was a best practice advisory that would pop up during scheduling, that would tell us if the case class did not match, was not a inpatient only class, then it would give us a warning to tell us, hey, this is an inpatient only procedure, and you don't have it scheduled as an inpatient procedure. And so we were able to put that in place. We now are looking at some other ways that we can use that, which I'll talk about a little later. So this slide again just really helps us, helps explain all the different ways, kind of what I was talking about with, those disparate dictionaries, right? Of the different ways you can name things and different things you can call it. And, here you have even that, with different facilities, what they each called it is maybe something different. And so this allowed us to really consolidate that information. And so you can see over on the right-hand side now, you have one standard procedure that really covers all 4 of those listed over on the left. You also have the CPT code linked to it, which you can search by the CPT code or by the term. But also one of the things I loved and that was really important to us was the aliases, because again, people may call things different things. And so this still allows us to at least search for procedures by an alias. One of my favorites, and I will be the first to say I'm not a clinical person, but one of my favorites is a laparoscopic cholecystectomy. People also call that a lap chole. People call that a gallbladder removal. So again, most of the time your surgery schedulers also are not going to be clinical, and so they may not know what to look for. So in that case, right, if somebody says I am trying to schedule a lap chole, they could actually type lap chole and it would give them all the things that have that as an alias, or they could type gallbladder and see everything that has gallbladder in the alias name. But it would still be using the same terminology and in many cases have one term linked to that. So that to me has been one of the greatest things about this. Next slide. So as we talk about the inpatient procedures and what we did around the authorization. So again, I kind of talked about on the inpatient procedures how at the point of scheduling now we get that pop-up that tells us if we don't have a match there. But now our next step is to take that information and use it at the time of the admission order being written to also fire a similar warning to say, hey, this you performed an inpatient only procedure. And so this patient should be admitted as an inpatient or vice versa, right? This is not an inpatient only procedure, so it should not be it should not be admitted as an inpatient. But again, one of the other big wins was really to get those CPT codes linked for even the authorization side. So outside of the Medicare inpatient only, it was really being able to have that handoff so that when the authorization team goes to authorize the service, they know what CPT codes that they need to authorize. And that may be more than one CPT code, right? So you may again have one term, but it may have 3 CPT codes that go along with that one term. And so they need to be able to know that. And so that information crosses over into our authorization form so they know exactly what to authorize. Next slide. So again, this is just, talking a little bit more about what we've been able to see through our use of IMO. Before we really were having to tap into what we called resource coordinators. We were having to reach out to our managers in the OR, our coders, several people across just to even get a term added to our dictionary. Now, really, what we can do is if somebody requests that, number one, most everything that we do today is already in our system. So it's really mostly going to be new procedures that maybe are coming along, or if a new provider comes along that maybe we haven't been doing those type of services before that we need to add. But then we can go into IMO's dictionary and easily search through those terms to find what we need. We do require them to tell us the CPT code. So again, we also have that balance, right, to say, let's look at the CPT code, what different terms are matched to that versus what somebody is actually calling it. And so again, that helps us narrow it down. And pretty much one person can make that decision now, but if they have a question, maybe a couple of people, but we've really reduced that need. Again, we were able to improve or reduce our inpatient only denials, as well as our authorization denials by doing this. And we really were able to hone in on our realistic scheduling and making sure that we are scheduling cases more accurately. Again, by having that smaller dictionary, we've been using Epic's procedure time averaging. And that tells us based on, how if they've done 10 of the same procedures before, then it's going to tell us, this is the duration. And so again, because we're using that standard dictionary, it's more likely that they're going to have performed that procedure before. And then we really are looking forward to working more on our patient-friendly terms and making sure those are crossing over into things that are patient-facing, so that just to make that more friendly. So again, back to my laparoscopic cholecystectomy, right? A layperson probably does not know what that is. That's probably not what the doctor told them they were going to do, except when they sign the consent. So they're just thinking I'm having a gallbladder removal. And so it could show to them as that. So that I think is going to be a great thing for the future. Another thing that we're really looking forward to, and we've just recently added, is the HCPCS codes. So the HCPCS codes now are available in IMO. Again, previously we did not have those linked to our surgical cases. So now we're finding that more and more payers also want those authorized, the device codes authorized. And so utilizing the dictionary and pulling those HCPCS codes over into our files is going to allow us to be able to also authorize those and hopefully reduce denials or at least denial write-offs associated with not having those device codes authorized.
We appreciate, Allison, your innovation and your willingness to adopt some of the new content we're embedding within Periop. I'm certainly excited by the results that you're seeing today, and we expect more to come. So we thank the partnership and look forward to working with you down the line. We'll open it up for Q&A now, and I see there may be a handful of questions coming in. Jordan, I believe you can open up the lines as well for folks who want to ask questions.
Yeah, so type them into your Q&A box. We have Wes and Allison here, but there are a few questions that came in already. So, Allison, how do you guys handle robotic procedures with coding and such?
Yeah, so I mentioned that briefly a while ago, but basically for robotic procedures, what we have done, um, sorry, I was getting a message that my internet connection wasn't good. What we have done really is we have duplicate terms in that case. So, we may have the laparoscopic appendectomy, but then we'll also have one that says robotic, laparoscopic appendectomy, so that we know that that is one that's going to be performed robotically. That of course is important because we would, you need to reserve the robot. I mean, we do need to have that separate term in there because of that changes the duration, it changes what room it goes in, it changes what equipment is needed, staffing, etc. And so it's very important to do that. We have some similar things that we've done with some of our cath cases, because some things maybe sometimes it's done in the cath lab and sometimes it's done in the OR. So again, they wouldn't be separate terms in that case, but because we need to indicate that the difference in the location, we have chosen to keep those separate. And so as we get the file back, every time it will tell us if we have duplicate, it identifies any things that are duplicate, and it pretty much always is going to mark those like those robotic procedures as duplicate. But then we basically just know to say, yes, we know that, and we want to keep these terms anyway. So it's a relatively simple process to do that at this point.
Awesome. What were the initial steps, Allison, that Piedmont took to identify and address like the inconsistencies in terminology and procedural codes across like newer acquired facilities?
Yeah, so what we really did was working with IMO. I mean, that was honestly one of the best things about it is IMO really helped us do the cleanup. So we basically downloaded our ORP records from Epic, so our procedure file from Epic, and we sent that to IMO. They went through and scrubbed it and kind of did the first pass on it. They had clinical staff that reviewed our terms and made recommendations. And then they sent that back to us with maybe questions, or if they needed clarification on things, they sent it back with their recommendations. But also, again, with those questions or some clarifying if things weren't clear. And then we had really a pretty small group of people that we identified from the get-go that were part of the project. So it was really myself, it was our Epic team lead, as well as then clinical manager and some clinical coordinators that we reviewed what came back from IMO and basically said, yes, that looks good, that's fine, or said, no, that's not really what we meant, or here's what our intent is. And so that was the process we went through. One of the things that stands out that I remember well was, and again, forgive me because I'm not a clinician, that we had to have some discussion around some of our oral maxillofacial surgery codes, because those can be broken down into some pretty minute details if you want them to. And so we really had to decide how much minutia we wanted to go to, right? Like how much detail, or, is it more we need some general information that's going to make sure we have, again, of course, the right procedure, but again, the correct things in the room and so forth. And so those were some of the decisions we had to go through, but overall it was a relatively quick process.
I can read the next two questions that came in, Jordan. I'll handle these. One question that just came in from the group: how do we arrive at patient-friendly terms as companions to clinical procedures? I'll answer that on behalf of IMO Health and the function in which, from a deployment perspective, So today, our clinical staff essentially identify one patient-friendly representation of a clinical concept that serves as a companion to that clinical concept. And upon a surgical scheduler selecting the clinical concept, and as Allison mentioned, they may have done so by searching for any type of alias, it will travel with one recommended patient-friendly communication that can then be embedded and distributed through things like MyChart or into any type of other billing application, et cetera. We certainly encourage all of the clinical content that's distributed through IMO Core Periop to be leveraged in every Epic system or complementary systems that benefit the operating room. A second question came in, given that we are supporting CMS's inpatient-only denials, are we taking steps to support CMS's ambulatory surgery center covered procedure list? Great question. We are hearing from customers at this juncture that they look to employ core periop into the ambulatory surgery world as well. So we are investigating creating additional flags that would operate in the similar fashion as our inpatient-only flags, and therefore help guide through an alert whether or not a procedure should be viable or coverable in an ambulatory setting.
Awesome. Thanks, Wes. All right, final question, Allison, and this is kind of coming from me, but what advice would you give other healthcare organizations looking to implement a similar solution?
I think to one, really make sure you have the right people at the table. Make sure you are, certainly communicating about the changes that you are going to make. You want to probably include some surgeons and make sure they're aware of those changes, because especially if they're utilizing your system to search for their terms or put in their case requests, etc., then they're going to need to be aware of it. That's one thing I didn't mention. We do get feedback sometimes, right, that things are missing from our list, and so again, that's where we can just easily go in and search. But I think, as with any change, right, it's about communication, and then having the right players at the table. So just keep in mind everybody that the change might impact. And again, those different points of view, because remember I talked about it as kind of that game of telephone of, how the surgery schedulers use the terms versus how the OR staff use it versus the surgeon versus the surgery scheduler at the office are all a little bit different. So just keeping that in mind as well.
I liked that response. Thank you. All right, so we are going to go ahead and close out for today. I know there are a lot of other ways that you can spend your lunch hour, but thank you so much for those who attended today. Thank you both, Allison and Wes, for this awesome conversation. And also, if you want to learn more about IMO Core Periop, you can email us at sales@imohealth.com. You can go to our website at imohealth.com, and we'd be happy to talk to you. I hope you all have a great rest of your day, and thank you again.